first thing that we did was with the childhood study group out of Chapel Hill, and we looked at how well we were doing our well child care, and were we hitting all the elements consistently and all the time. And we found that we weren't, even though we knew we were doing a good job. And that was the thing that, that really started us into looking at this whole issue of quality. One of the first things we looked at was asthma and how, as a practice, you can improve quality if you implement correctly the national guidelines for asthma care. In the year prior to our initiatives in asthma, there had been over 700 pediatric visits to our local emergency room with the diagnosis of asthma. The year following our initiative, there were less than 200. That showed us all that, wow, if we can make this kind of difference doing this kind of quality initiative, what else can we do?
I always, kept hearing comments saying, well, I mean, with the homeless, you provide acute care, you provide triage type of care, and it's really very difficult to manage, chronic diseases with them, very difficult to make an impact on the long term while managing a very transient population with the homeless population. And I actually really took that as a challenge. I said, you know what, yes, I can do it. Yes, we can make a difference. We can improve outcomes in our homeless population. That was the most important step. The next most important step was really to get the buy-in of the staff and the healthcare for the homeless program. And it was a shift in mentality for the program.
We started out as a very small 4-person group that had the vision of growing and developing a integrated cancer center in our community. What we know typically in oncology is that it's pretty much like other specialties, and that is people have to go to different places for different services. What we wanted to do was to create a fully integrated service, a fully integrated system and process. All of this is created for patient flow. Radiation oncology, medical oncology, laboratory, diagnostic imaging, and support services. The beauty of this is the integrated component of it, and it's got to be based around quality.
The first step in creating a clinical quality program in our healthcare for the homeless was to actually look at the Disparity Collaborative, take the chronic disease model by Ed Wagner, and try to implement it in that program. We've tried different options with data collection. We've started from using the tool that the Bureau of Primary Health Care had out there for the community health centers to use, to developing our own tool, then to kind of partnering with with our partner hospital and our partner laboratory to kind of get that data electronically from them and be able to work around it and be able to generate reports back, to the provider teams. And I think that has been very, very helpful.
The Division of Medical Assistance, which oversees the Medicaid program, understood the significance of improving quality and the cost savings that would come to them. And they underwrote our tuition to many of these collaborative efforts where we could go and get the training and learn the techniques. Had an opportunity to participate in a collaborative to further increase the quality of care for ADHD. One of the things that I gained significantly in my care of my patients was a greater understanding of the importance of the behavior modification part and the significant impact that can have. The collaborative allowed me to improve that aspect of how I was managing my patients, and I've seen significant success.
Change is very difficult. Change is very difficult in medicine, especially because of the deep grooves of tradition that exist in medicine, and deep grooves sometimes are hard to climb out of. What we try to do is to create a paradigm of why we do things, rather than saying we want to start an electronic medical record system in our practice. We want to give the reason why. So when we're actually able to demonstrate the outcomes of what we're measuring and show those outcomes to the people that are putting in that information, it makes adoptions much easier.
when you have a nurse who's been, you know, a nurse out there in the community under the bridges and in the shelters and in soup kitchens, and you ask that nurse to kind of try to collect data and will analyze the data. I mean, that needs a whole educational process. That to me was the biggest challenge. When we went system-wide, there was more and more resistance that I started to identify that I had to deal with. Then sometimes you gotta get to a point where you had to make, you know, a major decision and a hard decision and let people go, which is something, you know, nobody likes to do. But if you're committed to really making an improvement and making an impact, you really want people who are on board.